the screen to come on. We'll just make the slides bigger. I'm hoping if I could just get a thumbs up from someone that they're coming through very clear to me. Thank you very much. So thanks, lots of thumbs ups. Thank you very much. Right. Look, welcome to the event. Thanks for your time on this Wednesday evening. It's much appreciated. This is an important session for us all, and just to set out what this is about is making sure that the broader community in Derby and Derbyshire has a say in the national engagement process that both the Department of Health and Social Care and NHS England is running. They have asked us as the local NHS to deliver local sessions to our communities and receive that feedback so that we can put it into the national conversation that is live. Just a bit of housekeeping really from my point of view, because it's a national engagement exercise that we're doing. We're using the national material, so what you'll see in the slides and information to follow is the national information. That's really important because we need to ensure that that the public in Derbyshire gets the same messages as those in Somerset or elsewhere. So this is national information that we'll present. Of course, this is a helpful conversation for us to have locally, and there might be things that come up that are local in nature, and we'll do our best to feed those in as well. But actually, it's about the broader NHS itself. In terms of what's we're going to do, and I'll look to Beth and to Mark and to Jim to keep me on track. What we're going to do is take us through a few parts of the NHS 10-year plan, and we're going to stop and we're going to use the Slido technique that you've just been doing your Disney favorites on to just gain that feedback, but we'll also be keeping an eye on the chat box as well. Huge thank you in advance to our BSL interpreters. Thanks ever so much. I know how hard work that is as well, and we'll do our best to help you with keeping the language straightforward and not too technical. But I hope that's helpful. Are we ready to go on to the next slide, Beth? So, what's this going to get into? It's really about hearing your views about health and social care and the importance you put on it and what you want to see. We will use this feedback. We won't just use it for the NHS engagement programme. We will use it as well. We'll use it as well for the local NHS work that we do, something called the Joint Forward Plan, which I'll say a little bit about that as well, and we'll also use it to support our development in the local NHS and care service. So I think I've said a little bit about the NHS 10-year plan. I'll just say a little bit, if I can, around this thing called the Joint Forward Plan. So a couple of years ago now, the local NHSs were asked to create a 5-year plan for our local NHS. We're a couple of years into it, but we always develop it every year. We review it, check it, and make sure it's still fit for purpose and we're going in the right direction. And so anything that we gain from tonight's conversation to support the development of our joint forward plan we'll obviously use in addition to feeding back into the national process. Okay, Beth, am I all right to have the next slide. Okay, so just a little bit of a potted history if I can. So we all know that in early July there was a general election, and we uh, have got a new government, and the new government has been really, really clear about health and healthcare, and the importance of that to its mission while it's in government. It did a couple of things early on. The first thing was that it recognised the challenges faced by the NHS right now and set off an investigation very, very quickly from the government taking office. And a gentleman called Lord Darcy did an investigation of the NHS and found lots of things and raised lots of points about the challenges the NHS faces. And in response to that, the government set out the need to create a 10-year plan for both the NHS and broader health. And in that plan has been really clear about something that we call the three shifts and the three areas of real focus. And anyone who's been engaged with health and care development locally will know that we've been talking about these for a long time ourselves. So it's great that we've got alignment with national views of the situation, and all of them are important. So they're not in any particular order, and I think as we go through, we'll take them in a slightly different order. But moving from left to right, the concept of moving care from our hospitals to our communities. Now, we all know that we do a lot of health and social care in our communities where people live. We do a lot. But the principle around this at the moment is that over many, many years, the NHS has been particularly focused on developing hospital care, and of late we've seen across the country that our hospitals have struggled to manage all of the care that goes before them, and so we're seeing large waiting times for people who need routine treatment, or waiting times in our emergency departments. So the focus around moving care from hospitals to communities is around building more care in our communities so that our hospitals can really focus on the things that only they should and can do. And so whilst we do circa 70% of care currently in our communities, be that in our general practices, community services such as district nursing and care services, actually we want to do more. So that's principle shift number one. Like I say, they're not in any order, but that's where they are. Shift number two, in sort of middle of the table in front of us, is around making better use of technology. And again, those that watch the news or stay connected to health and care developments won't be surprised by this. That actually, amongst along with all of the sectors out there, we want to see technology being further advanced and supporting the delivery of healthcare and helping us really focus our people on the things that they need to do and the skills that they have, and assisting them by being better, using technology, further. Good example of that is around the electronic patient record and making sure that everybody has access. Our clinical colleagues working with patients have access to electronic patient records and also can share information between relevant agencies where that's required. But also we're hearing a lot around artificial intelligence and seeing it being used in a lot of sectors around us. And so what's the use for artificial intelligence that the NHS could benefit from, done in the right way and in a carefully thought through way. And then the third shift is this concept of preventing sickness, not just treating it. And and you'll hear this described in different ways. So a lot of us, recognise the health service at the moment is predominantly focused on treating people when they are ill. We do a lot of prevention work at the moment and trying to prevent people becoming ill in the first place. But actually, this is wanting us to move more into that space and do more prevention. Now, of course, not all prevention can be done by the NHS on its own. So there's a real point here around the NHS working with other partners around broader prevention work. A really good example that we know very well locally is if we want to prevent heart attacks and stroke disease, which is sadly still a common cause of death and disability in our society, actually picking up people's blood pressures earlier before they get too high, or helping people to stop smoking. Those are really important prevention schemes, and if we can do more of that, we can then focus our treatment on, in a much more considered way. So those are the three big shifts that are coming out, and we'll talk about tonight and gain your views on and your experiences on, and we'll sort of guide our thoughts. So I think, Beth, with that, I'll go to the next slide if that's okay. So I think this is the point where you take us through, join in Slido, we get Mark on hand for any technical guidance, and we get your early views on what you've heard so far. Thank you.
Thanks, Chris. Yeah, so this is what we're going to do is a bit of a warm-up activity. We've got 3 questions as a warm-up activity. They all still go into the portal to develop the 10-year plan, but it's a bit of a dreaming exercise. So we're looking at aspirations. So I'll go on to the first question. I've only got one screen, so I'm assuming that Mark's putting the links in the chat for us. If it goes on to the next one. So, hang on, it's gone. Oh, bear with me. I can't go backwards. Try and see if I can go backwards. Just bear with me. Let me sort this out, and I'll go on the. Let's restart my thing again. And start from there again. Sorry, my Slido's playing up a little bit. Right, so let me try and share my screen again. I always have these technical difficulties at some point. It's going to start from here again. Okay. Can't get back to that first question. So if the 10-year plan is a success, what will be different? So the next one will be about what will be the same. So just to give you comparison, that will be coming up next as well.
So Beth, you'll just stop sharing for a second because you're showing something different at the moment. Let me see if I can share that question. Is that the question that you want?
Jim, I think it's 2 slides before that. I think. No, go. Sorry.
There it is.
You want that one?
Yeah, but yeah. Now go one more. I've got a feeling Beth's frozen. Mark,
Yeah.
have you got access to the Slido installed on your computer to be able to share? Jim can't share the live Slido because he won't have permission to use it.
Just bear with me. I just need to find that, Sean. I wasn't expecting this.
I think what's happened is Beth's connection's gone. She's disappeared, hasn't she? I think she'd frozen. That's why she didn't respond to you, Jim.
Okay.
We'll get there. Give us 30 seconds. We'll sort it out.
It's all good. And look, we'll put some music on or similar while we're waiting. But it's like one of those things. It'll be all right on the night. These things did work in practice, so we will. We'll get it to you as soon as we can. But whilst we're doing that, you've got the question that's coming, so you can be just thinking that through. Apologies for just the technical difficulties, but we'll be with you as soon as. And thank you, Jim, for stepping in there. That was very quick. Perfect. Thank you, Mark. Right. So, Sean and Mark, we're going to ask colleagues to going to ask members of the public to go to this first Slido, I think.
Yeah. Yeah. So this first one's just about how the NHS feel in the future. What 3 words? You'll see people typing. Just to say, while everyone's having a think about it and typing in, this all gets captured. So will this all get fed and themed into the reports that we submit? Barbara, I can see you've got your hand up. Did you want to come and speak? Oh, it's gone down. Oh, no. But still see the numbers are still ticking over, so we'll leave it running. There's a lot of replies in there, but still members typing away. Okay, still people.
I'm just noticing, Sean, that if those that can't use Slido are adding some comments in the chat as well, so it's okay to do that.
Yeah, definitely. We'll capture all that. That's one of the options that we said. People can use either the phone or the desktop or the laptop or the chat. Everything will get captured. Perhaps we'll just say another maybe 20 seconds and then we'll move on to the next question. The challenge is once the question moves on, you won't be able to add any more comments into it. So there is a whatever it's on the screen you can type. There's still people typing, so I better stop talking and putting people off.
I think you're right, Sean. Once we see that nobody's responding, we'll move on. We need to capture everything, don't we? Yeah. Give it a few seconds of inactivity, and then we'll move on.
We need a countdown theme tune.
I think you should do that, Sean. And ultimately, we could give people 20 seconds or so just to round off. And if they've still got some thoughts that are burning, they can pop them in the chat, can't they? And we can still capture those.
Great idea. And Sean, from memory, the bigger the word on the screen, the more people who have picked that. So it gives you a sense of smaller words, less comments, and then the bigger words. There's a lot more consensus around those. That's helpful to see.
Yeah. Okay, I think we've come to a natural point now. So Mark, are you okay to move us on to the next question? So obviously colleagues have I think this is the one that Beth skipped to by mistake. So that's why there's some words already in there because members of the call will have done the code and started typing. So again, if the 10-year plan's a success, what will be different?
I apologize, my computer crashed.
It's all right, Beth. It's all right.
Seamless, Beth. Seamless. Yeah, nobody noticed. It's all right.
Yeah, just reading the chat. Any words that you haven't been able to put in the previous one, if you put it in the chat, we'll make sure they go into it as well. So anything that's been put in the chat will be put into the Slido, into all the combined results. I think it is good on this Slido that when words are repeated a lot, it starts making it larger and larger as well. So you kind of see what sometimes a bit of the majority or what the consensus is going on. So obviously with some big words here around prevention, equality, access. I'm just going to pick up taking from my screen now, but it will just slip over to mine. Just checking on timing. So I think if we move on to the next one, if everyone's happy with that. Again, if you did have some ideas around the other ones that you wanted to pop in, just pop it in the chat and we'll make sure they go in as well. So the next one is, if the 10-year plan is a success, what will be the same? So it's probably like the positive aspects, just thinking about your different journeys that you might have had. Yeah, so straight away we can see that care's really standing out there. Yeah, free care. Some of the pillars of the NHS are coming out. I think these exercises are really good because it gives us, as a plan, something to aspire to as well, doesn't it? Compassion coming out there. Quite a lot of areas around communication as well. The import. Yeah, I think there's a really good range coming out, but you can see some quite common themes coming as well, which I think is really interesting. We just spend probably about another 1-2 minutes on this, and then we'll move on to the next section then. Okay, wonderful. All right, I'm going to wind down on this one now. I think we're going to hand it over to Jim now, who's going to talk about making better use of technology. Again, just as I said before, if there's anything else you want to add into this as we go through, just pop it in the chat and we'll make sure they go in as well.
Thanks,
So
Beth.
I shall hand over to Jim.
Thanks very much, Beth. And so, Jim Austin, for those that joined after I did my introduction, I'm Chief Executive of Derbyshire Community Health Services, one of the NHS providers in Derby and Derbyshire. So I'm going to cover for about 5 or 6 minutes just a little bit of background around the insights that we have around making better use of technology. So on the next slide, thank you very much. We've collected insights to look at what the people of Derbyshire have already told us, and we split this into positive and negative themes. And you'll see in front of you now some of those positive themes. I'm going to run through a little bit of each of those, and Chris has covered some of those in his introduction as well. We've actually got about 30 pages worth of these insights that people have already provided us, and we'll share a link at the end of the presentation if you want to go and see those and add to them as well. So I'm just going to quickly run through the positives that we nationally and in Derbyshire will see, we think, from the move from analog to digital, or improving our digital capabilities. So the first one is around greater accessibility. And today's a really interesting example of that, isn't it? We've been running face-to-face sessions across the county and city. And here's one today, this evening, that for some people is significantly more accessible because of the way that we're doing things. And so there's opportunities to think around virtual appointments, remote monitoring, and allowing patients and citizens to access care from their homes, and particularly benefiting those with mobility challenges or living in rural areas. So there's an opportunity there. There are efficiency gains that could be drawn through with digital tools. And Chris alluded to something called the electronic patient record. And we have one of those in Derbyshire where we can share information across clinicians and sometimes to social care. And that can allow for greater efficiency in the treatment of patients. We may not have to order as many tests for people, but it could also help with patients when they're explaining their conditions, because clinicians can see the history of what's going through there. So there's an opportunity around efficiency. There's patient empowerment, and some of you may be using the NHS app or various apps, applications to assist with conditions, and they can also help with things like appointment booking, prescription management, self-monitoring, and give patients more control over their health. There's an element around proactive care, so using predictive digital tools and integrated systems to support earlier identification of health risks. And Chris touched a little bit on AI, artificial intelligence, earlier, and you've seen some of you may have seen some announcements around that by the government in the last couple of days. But we think we can improve patient care and pathways, enabling timely interventions through that proactive care piece and using digital solutions. And then finally, innovative solutions. So blended care models combining digital and face-to-face services more flexibly. So sometimes you might see a clinician face-to-face and then the treatment would continue using a digital intervention. So those are some of the positives. If we just move on to the next slide, there are some concerns that people have raised with us or that have been raised nationally. And these outline some of the negative aspects of technology that we've heard from people. So digital exclusion. So today, I would imagine that the 50 or so people that we have on the call will feel quite digitally literate and available and able to interact safely and carefully and well with technology. But there are groups of people where what some people would call digital literacy are struggling. There's also elements around the ability to afford digital interaction tools as well, and that leads to part of exclusion. Reliability issues, well, we've had a few gremlins today, haven't we? So there are some questions just around technology. How good is it? How robust is it? And how easy is it to use? And even actually in some of the interactions we've had around the words earlier, you could see that what could be seen as quite a simple instruction can be interpreted by different people in different ways. And that could be a reliability issue as well. So we'd have to think about how we challenge that. lack of integration. So while I've talked about the shared care records that we have and the ability to connect data for clinicians to see and patients to help with their conditions, we still have quite a fragmented platform, and that can create confusion where people might not get the right information at the right time. So that's an area of challenge for us. There is some reports of perception of reduced care. So a perception from some people that technology reliance reduces the personal interactions. If I'm doing something face-to-face or on an app, would I get a different service and a different kind of interaction if I was speaking to a doctor or a physiotherapist or a nurse? So that's a concern that people have. And then finally, when it comes to digital, we often put the data element within that, all our personal data. And there are concerns that people have around the lack of transparency or the data, the way we use data, and people would want to understand that. Can you move on to the next slide, please? So what's the challenge? So we still have some parts of the NHS relying on paper and pages and slow computers, and we've got uneven use of new technology, and you know, the digital literacy that we talked about with the population generally relies within our staff rates too. You know, our staff within the NHS are made up of citizens from within Derby and Derbyshire, and they too will struggle with that. Christine, I can see you've got a hand up. I'll come to you in a second if that's all right. Let me just get through these slides and I'll come back to you if that's okay.
Thank you.
Okay, thanks. And we've got some talented staff, and you know, sometimes they struggle with some of that technology, and how do we help them with that? And you can see from the next box along, we've been investing in digital technology, scanners, machines, and we're using shared care records and investing in AI tools. So that can help to overcome some of that. And the impacts that we can see will help us to reach into some of the areas that Chris was talking around, diagnosing illness early. That can help us with some prevention, improvements in patient care, and less administration for staff and also for their patients. Move on to the next slide, please. I think. Here we go. So we're going to do the same kind of Slido exercise again. And if the questions and the words we'd like you to fill up now are, when you think about how we could use technology in the NHS, what are your hopes? And while people are doing that, Christine, you've got your hand up.
Yeah, I mean, both Derbyshire Healthcare and the Royal are on System 1. So why is it every time you see a consultant or a clinician, you have to keep giving them the same information at each appointment, which takes up about 10 minutes of your appointment time? Why isn't it up to date, and why aren't they using the system to what it's supposed to be used?
Yeah, and Christy, because this of the kind of engagement session we're doing now, that really specific question, which I could give some answers to, but it won't satisfy you in this forum. What would be really helpful is if you look at this question, that's exactly the kind of feedback we'd want to put in, which is what do you think we could use technology in the NHS? What are your hopes? And your hope would be that whether you're in the community or in an acute, that your clinicians have got access to the same information. Does that make sense? We can use that as the mechanism rather than trying to do individual questions.
It's because electronic patient records, if they're not being updated by the people that you see, then why have we got it? Because it's not being used to its potential.
And I think that's exactly the kind of feedback we want to put into the questions here and the answers here. Thank you.
Thank you very much.
Yeah, thanks, Jim. And so yeah, we've got two questions around the digital area that Jim was just talking about. So this is first question is around what the hope. So what, again, talking about the aspirations, where do we want to be? And the next question is talking about what fears might be. So just keep that in the back of your mind. We've got about 10 minutes to do these two questions. If there was any comments or any kind of questions related around this area that people wanted us to ask or discuss at this moment in time, please just let us know. You can either put something in the chat or raise your hand as well. So as you can see as well, as people are putting in comments, the technology is starting to, or the Slido is starting to theme things as well. So you can see at the top there, it's saying there's 5 comments around access, there's 4 comments around system, which is really useful. Obviously, it does have limitations still, but we still need that human element to make sure that everything's kind of right when we look at theming. But it's good to kind of get that overarching view. So lots of it is about access around technology. And obviously that hopefully digital technology can actually improve access and support with getting information out there as well. So that's some of those top themes that are coming through there. I see quite a few people are writing. Anything in the chat, Mark? Any questions or anything that we can draw on?
No questions, but plenty of things being loaded into Slido.
Yeah, wonderful. We'll just give people a few more minutes. We've still got quite a lot of energy I see on this one, so I'll just leave everybody to it for a minute.
I can see lots of people typing, Beth. And what's interesting for me is the Slido, that the little columns that are forming up around system, information, patient. That is, in fact, some artificial intelligence being used to this process to help us consolidate the information. So we're still in the foothills of some of this within the NHS, but you can see that some of the technologies we can apply can be really helpful in theming things, at least.
Yeah, definitely. Some really overarching themes there. So one about obviously the hopes around improving the system, around improving that information, technology, getting appointments, and then obviously patients. I'm not quite sure that relates to it. Might be experiences or the treatment and the access as well. So.
And like I said, there's an interesting comment there that just on my screen at the moment around technology being applied to buildings and services and not just patient care. And clearly a significant amount of the work we undertake with the NHS, huge majority is patients' work, but there is a significant enabling service that sit underneath that to allow us to deliver that care.
Yeah, and I think it comes to the point that, is it Chrissy that just spoke that was talking about, is that back office functions as well, that it's massively useful in primary care and in hospitals as well. Okay, I'll just give people another minute on this one, then we'll move on to the next question. Yeah, again, obviously about offering emails and texts for deaf patients, so it's like increasing that access and communication for people as well.
It's interesting that I haven't seen a comment come through just around technology helping with language as well. And we have quite a diverse set of languages across our footprint across Derby and Derbyshire. And most of our communications are done in English. There are some significant exceptions to that. We work very hard to try and be better at that. That is something that digital could really help with in the future.
Yeah. Wonderful. Thanks for that. That's brilliant. Really good. Some results there. I've got two people still. Okay, I'll give people another minute there. Sorry, I thought everyone stopped. Interlinking those ones, put a comment around education on prevention health as well. So that's interlinking with the shifts as well that we're talking about.
Yeah, and I saw a link earlier around out in the community and assisting with connectivity there, which after the break, I'm going to get into a little bit around the acute to community shift.
Yeah. Yeah, neurodiversity, accessibility as well. That touches with obviously communications as well, doesn't it? Okay. I'll give about 10, 30 more seconds. This one person just finish off typing, and then we'll move on to the next one. So the next one is around. I'm just going to move on just around times. Obviously, if you're not filled that on, just pop it in the chat and we'll move it over. So the next one is around when thinking about how we could use technology within the NHS. What are your fears? So what are some concerns that people might have about digital technology? Yeah, some about our reliance on it. Things around data breaches, around security concerns.
It's interesting watching these comments going through and these are the national questions that we're trying to answer, and that's Chris outlined the constraints that we have around that. It makes you want to probe some more. Some of the answers, there's a kind of so what question that falls out of the back of these. So it's really interesting to see some of these coming through. And like many things, the fear is the is the opposite of the opportunity, and it's how do we manage both, because the opportunity will come with risks and we have to be able to manage both.
Yeah. Oh, sorry, Jim.
No, I'm seeing quite a lot in there about backup if systems fail, and you'll be aware in the news and media there have been a number of systems affected, with cyber attacks and things like that, and it really does. Our reliance on digital. I was thinking about Barclays Bank over the weekend. If you're a Barclays Bank customer, had a real problem with their app, and it can really make a big difference. So there's a lot of work we'll need to do to make sure things are robust. There is nothing more reliable than a pencil and a piece of paper, because a pencil can even write on wet paper in the rain if you have to. However, it's going to struggle to get some of the messages around the place quickly. Sorry, Beth, I cut across you there.
No, it's fine. I was just reading some of the comments. I thought they were really interesting. I think I saw one comment around translation not being correct in different languages, and I've worked with some communities before that have raised that concern and wants to do translation within their own communities so they can sense check it, because things don't directly translate. So I thought that was an interesting point. I think people have put around that, obviously, that concern about leaving some people behind or some communities behind. So people might be living with disabilities or learning disability, and just making sure that they're all included as well. So yeah, just started looking at the themes as well at the top. So looking at lots of around human elements, around the technology itself as well, and then obviously a couple around people and the care concerns and the data.
Yeah, I saw the comment human error coming through, and of course humans will make errors. We're human beings. It's interesting, we then set the technology standard to be perfect. So there's something just for us to reflect on around how perfect do things need to be.
Yeah. Is there any questions or comments in the chat, or if anybody did want to ask any questions around this element of it, then please just pop your hand up.
So as you say, Beth, I think we've got 4 or 5 minutes before we're going to take a break at the end of this one anyway, for people to just have a short break. But if people have got any questions, really happy for you to put your hand up, and I'll do my best not to do what I do with Christine, which is immediately close the question down. So I'm sorry about that, Christine, but it felt like that. But if there's any generic stuff, really happy to try and take that on. Barbara. You're on mute, Barbara, at the moment. Did you want to speak, Barbara? You've got your hand up, but you're on mute.
I know Barbara joined us earlier. I know there was an issue with her unmuting herself, but it did work out eventually.
Maybe pop your question in the chat, Barbara, and I'll try and look out for it. I can't hear you at the moment. Just while we're waiting for Barbara, Fiona, did you want to come in?
Yeah, I was thinking about the problem they've got with AI and other technologies, where there's a kind of inbuilt gender or race bias. And it does come up a lot in education. And I wonder whether there's a consciousness, I'm sure there is, in the NHS about those problems. In other words, the software unintentionally has a bias built into it.
Yeah, so it's a really interesting topic, and what I would say is it's not only the algorithm or software that has the bias, it's the learning set of data that has the bias. And so if your learning set of data is from the population you're attending to,
that's right,
then that can help to reduce the bias that might be there. The challenge comes from if we were to take a set of data from North America, their population is very different from what we would have in Derby and Derbyshire. And actually, you could argue that even the demographics we have between Derby and Derbyshire is different. And so you'd want to make sure the learning sets are appropriate to the populations that you're attending to.
Yeah, I think that's true. But I think also that within protocols, you get this problem of it's an unseen bias. It's not, you might find that in a more obvious way if you're comparing data from different populations, but there can be a generic bias within a data. And I just wondered I'm assuming that you're aware of this and you're working towards getting rid of it, etc. As we are in education, it's exactly the same problem.
And you've described it well. I think we're both cited on it. I'm not sure I've yet seen the evidence about how we overcome it. And part of the challenge with AI, and I can see it coming through the commentary as well, a lot of the AI is a kind of box, and you can't see what's inside the box and how the algorithms work. And that's part of an industry challenge we're going to have to face. How do we open up the box that people can see how it works?
Yeah, you're right. Yep, I agree.
Yeah, it's a brilliant question, Fiona. I think Barbara's managed to unmute now. So can you ask your
Yeah,
question,
sorry about
Barbara?
that.
Yeah, there we go.
Unfortunately, I can't write on the screen. I can see all the questions coming up, but I can't add to them, unfortunately. The one that I would like to add to this is the fact that when letters come through as from a consultant or whatever with as diagnosis, it'd be worrying if the patient received that before they'd had the proper discussion about that medical condition. Just to read the letter from the consultant to GP before that discussion, which could happen in the situation if everything's going on to patient access from the hospital.
Got it, Barbara. Thank you. We'll make sure that gets captured. I can understand the concern there.
Thank you. I'm sorry, I don't know why I can't write on the screen.
Don't worry. This comes back to some of the challenges of technology that were there.
Yeah, definitely.
You're a brilliant case and example of the things we need to consider. Thank you.
Okay, wonderful. I've just got one person typing now, but I think this is getting really good comments. I think I saw one earlier around the safeguards in place as well, around people maybe being coerced as well. So I think that's a human safeguards need to make sure that are in place as well. I think we're about done on that question. I know one person's typing. I think we're just about coming up to a break now. So I think we're going to have a break for around 10 minutes. So if I can ask everyone to come back around 7:05, and then we'll restart again, if that's okay. Okay, thank you very much, everybody. Join back at 5:05.
Thanks, everyone. Beth, it's Jim. I've just dropped you a message in Teams on a different channel. Don't know if you can see it or not. Oh, you're on mute, but don't worry.
Beth, I'm just looking at Hamza's comment in the chat about the BSL interpreters. I did notice that.
We're both still here. We were going to put our
Hello.
cameras on at
Hello.
7:05,
Of
as Ben
course.
said.
Of course.
Yeah. We didn't go. We're still here. Just cameras off.
Lovely. Thank you.
I'll just give everybody a couple more minutes, then we'll get going again at about 5 past. Okay, everybody, I hope everyone's now refreshed, got a fresh cup of tea going. What I'm going to do is I'm going to share my screen again, and then I'll hand back over to Jim, who's going to talk about moving care closer to communities. So I'm going to share my screen, bear with me.
Thanks, Beth. So just like before, I'm going to take 4 or 5 minutes just to go through some key points for us to consider before we get into a couple of questions to do on the Slido, like we have done before. So if we just move on to the next slide, please. So just to start with, what do we mean by healthcare that's delivered in the community? Healthcare in the community provides support to help people stay healthy, manage long-term conditions, including some scans and tests, and live independently at home, or the place they call home. People of all ages use healthcare in the community from birth to end of life, and you can see in front of you some of the different places that we deliver care in the community, and by the people, the healthcare professionals, and many others who do that. So I'll just run through some of those. In fact, I'll run through them all quickly. So in the community means people's homes, community clinics, schools, care homes and hospices, pharmacies, and that's often delivered and supported by the voluntary community and social enterprise sector as well, or VCSE, and you'll hear about them in many of the conversations we have within the NHS. And they're delivered by lots of types of healthcare professionals, is what the slide says, and we've added a bit at the bottom, which could be district nurses, pharmacists, end-of-life care nurses, allied health professionals, so there's a physiotherapist, podiatrist, speech and language therapists, paramedics, there are many disciplines there, midwives, health visitors, healthcare assistants, GPs, of course, dentists, social workers, the VCSE sector that I've talked about, and of course we deliver a lot of care through the public, through carers and self-management as well. Just go on to the next slide, please. So when we've looked for key positive insights around what does that mean, moving care out of an acute hospital setting and into the community, what are the things that we might want to bear in mind when we're thinking about the questions? So firstly, improved access. Services such as mobile clinics and local community hubs have reduced travel times and made care more convenient for patients, especially in rural areas. And the home first approach has enabled faster discharges and recovery in familiar settings. As far as integrated services go, initiatives like co-located services, e.g. diagnostic and mental health support, have improved care coordination, reducing hospital dependence and ensuring smoother transitions for patients. Community-based models for chronic care hubs and proactive care models, such as a falls prevention programme, have demonstrated success in reducing hospital admissions and supporting long-term health management. Patient-centred care talks about tailored discharge plans, including home adaptations and follow-up support, empowering patients to manage recovery more effectively while minimising stress. And then equity of access. There are efforts to provide culturally competent care and extended services to underserved areas that have improved to improve fairness and inclusivity in healthcare delivery. So those are some of the positives that you can see from moving from an acute to a community basis, but there are obviously some concerns that get raised as well. So some of the things that have been highlighted include communication problems, where poor communication during discharge processes can leave patients uncertain about follow-up care and their next steps. For example, in one report, 77% of patients surveyed were unsure who to contact after leaving hospital. Resource shortages. Delays in arranging home care services or transport and discharge paperwork can hinder smooth transitions and create frustrations for patients and carers. Delays in processes. Patients often face long waits for discharge-related tasks, such as receiving medication or arranging transport, which could negatively impact their experience. Limited awareness. Many patients and carers are unaware of community resources available to support their recovery, leading to missed opportunities for better care. And I think I'd go further than that. I think, I lead a trust that is based in the community. There are plenty of our professional colleagues who also don't understand the services that are available, and that links very much to the voluntary and the voluntary sector that we talked about a little bit earlier. And then finally, cultural barriers. Marginalised groups, including Black, Asian and minority ethnic communities, face challenges accessing care due to systemic inequalities and a lack of cultural competency amongst healthcare providers. So these are some of the concerns that you might get around thinking about moving from an acute setting to a community setting. So just go on to the next slide, and this is the slide I'm going to finish on before we move into the question. So in a kind of summary, moving care from hospitals to communities, the challenge could be perceived as there's a challenge around, well, it's not a challenge, it's a good thing. People are living longer, but with more health conditions. And at the moment, we treat a lot of those in our acute hospitals. And treating people in hospital is expensive. It's where most of the NHS budget is spent. And this can then lead to the demand that we're seeing, and we're seeing it particularly in pressure across Derby and Derbyshire now, as we are nationally. That can lead to sometimes long waits at A&Es, lengthening waits for hospital treatments and mental health services. So moving from delivering lots of care in hospitals to delivering more care in communities, pharmacists, GPs, those kind of areas, and in people's homes could be a solution for that, and is the direction of travel that the 10-year plan is seeking to direct, and that Darzi, Professor Darzi, that Chris mentioned at the beginning of the call, is recommending. And it's perceived that the impacts would be more care in communities that would be suitable for people's needs, and fewer people going to hospital, which means hospitals can focus on emergency and specialist care. So I can see that in the chat, people are already beginning to give opinions and views on that. We'll capture all those, but I think we're going to move now into the Slido element, I think that's right, around what positive differences would moving care from hospitals to communities make to you. And if we could get into that piece next, and again, please feel free to use the Slido to put your words and comments in there. Use the chat if you want to, and I can see that people are already there doing that. And if you can't do either of those, put your hand up, and between Beth and me, we'll come and try and ask you what's going on. Thank you.
Brilliant, thanks, Jim. Just to let everybody know, there's two parts to this question. So this is around the positive differences. The next one after this will be about the negative or concerns you might have as well. So just keep that in mind when we're writing these as well.
I think to reassure you, if you've put stuff in the chat, we will make sure they get captured and put into the relevance of the two questions, because I can see that in the chat there's a bit of some negatives and some positives. We'll make sure this get captured. No need to do it twice, as it were. If you've done it in the chat, there's no need to do it on Slido again.
Yeah, I think some good points already coming through. It's obviously about access is being raised, about locally, it's being familiar to people, also better on the environment in regards to travel as well. So some really good points, obviously starting to theme them at the top there as well around access and time. Yeah, about pharmacy, having more controlled drugs ready available. Yeah, that's a big point as well. Someone's put around the risks of hospitals in regards to infections as well.
Yeah, I mean, colleagues in hospitals, in our acute hospitals, work phenomenally hard, and they're under real pressure at the moment. We'd really want to be in a position where you're only going to hospital if you absolutely needed it, and when you need to go, don't you? And this is around trying to think about what else could we do. The expression that the New Zealand Health Service use is only do in a hospital what only a hospital can do. That's quite an interesting way of thinking about how we might want to attend to this ambition in the 10-year plan.
Yeah, some of those themes really gaining some momentum now around, especially around time being saved and hospitals as well.
Yeah, and I'm picking up a theme around people actually being quite frightened to go into hospital as well, which is interesting, just around the risk of them picking up an infection, or just the whole thing being a frightening experience. And I have to say, I've only been in the NHS 10 years, and I still struggle sometimes to go into some of the big hospitals.
You know, just a point there around rural communities as well. Obviously having big travel distances for some communities in our area. We've got a very different range across our Derby and Derbyshire in regards to city and rural communities. Let's give people a couple more minutes on this one, and then we'll move on to the next one, which is more around about the concerns. Any questions from the chat, Mark?
No, there's been some discussion, a few points, but no questions at this time.
Yeah, that's another really good point. That top one there, I've just seen around visitors. Obviously, if you're having to go somewhere quite far away, not having that support from carers or family as well to be able to visit. Okay, I'm going to move on to the next section. Again, just put anything in the comments if you have any further thoughts on that one. It lets me anyway.
Or Beth with her gremlins. I'm just thinking if we end up dwelling on this slide about all the positives, we'll miss the point about some of the areas of challenge that we've got. There we go.
There we go. It worked. Yeah. So this one obviously is about those negative, all those concerns that you might have about moving care from hospitals to communities. Representative and GPs, PPG groups, one's mentioned there, so that's patient participation groups. So they're the patients from a different GP practice that represent their population. And they're looking at the resources, potentially putting more pressure on staff that are potentially already overworked as well, around capacity.
I could see a comment from Lucy Kerr who's having to leave, and just to, if you're still there, Lucy, I think that's exactly the session we're going to get into after this one. I'll put a quick of a thumbs up on it, but we'll make sure you can have the opportunity to feed into that. So I can see a theme coming through around community resourcing, and I think you could argue that any part of the NHS would argue a case around resourcing, but also a link to the pressures and stresses and strains of carers and families looking after people in the community as well, and would there be a greater reliance on that? So I think that's a theme that I can see coming through. There you go.
Yeah, like of interpreters in the community, someone's flagged on that one. Again, around costings, you know, is it expensive to set up lots of local hubs with diagnostic equipment? And clarity too about who is responsible for what as well. Obviously, NHS and working together with different services around public health and councils as well. It can be quite hard to navigate.
Yeah.
I've done that with a kid.
I think that was Carol Stone, but I couldn't quite make out what she was saying. I think it's really useful, and I'm definitely wanting not to try to respond to the points in the chat, because the point of this is to collect your feedback, and then we will work through with NHS England how we need to think about and address the points that you're raising, because they're all good points. And one of the things that was covered right at the beginning, just remember, is there are no wrong answers here. These are all really valid opinions that are coming through that will allow us to consider and try and plan for and accommodate the feedback that we're getting.
Yeah, there's a great comment there around health inequalities, around that health inequalities is often geographical. So how do you understand where needs to get resourced and what? Which I think is a great point to raise. Yeah, reliance on unpaid carers. So just seeing at the themes at the top as well. So carers are coming through a lot as well, and concerns around patients, and then around the actual community and hospitals as well.
That's all right.
I'm not sure if Carol's actually trying to say something, or if a mute just keeps coming off a little bit.
I think it might be just popping off because she's quickly going back on again. There's some interesting elements here just around the links with social care as well, actually, and I think that's a really important point to draw through. That I've talked a little bit about some of the healthcare professionals and families and voluntary sector. Clearly, we have to work hand in glove with local authorities and social care as well. And so as we propose the shift out from acute and into community, there's clearly going to be a need to work very closely across the board there.
Give people from 1 or 2 minutes left on this one, and we'll look at moving on to the next section.
I'm not going to bother about it. I'll just tell about my job.
So just while we're into the last 90 seconds of people doing it online here, really happy to take if anybody wants their hand put up, if they feel they haven't had a chance to mention something, really happy to facilitate that last bit, because this is the end of my bit of facilitation. I've done my 2 sessions and I'm going to be handing over to Beth and Chris for the last bit. But if you've got any questions or you want to put your hand up, now's the time to do it, particularly on this element, which is around acute to community or hospitals to communities.
That's brilliant. Okay, I think we're going to move on to the next section then. Everyone's happy, if my PowerPoint works.
It's been a day for gremlins for you, Beth.
It doesn't. I've lost my mouse.
Here we go.
There we go.
You're on.
Go back one. So if I hand over to Chris now, who's going to talk us through this next shift, which is around preventing sickness and not just treating it. So if I can hand over to Chris.
Thank you very much. And yeah, thanks, Jim, for taking us through those previous 2. This is the one where we've talked a lot about over the previous years, and one of the big challenges, of course, is when the health service is as busy as it is, how do you focus its attention on the challenges and problems of tomorrow? And that's the key thing for us. We all agree this is what we need to do more of. The trick for is how you do it. So just to remind members of the audience around good health and what determines good health. So those that have heard us speak before will have heard the phrase the determinants of health. So in other words, what are the things that we encounter in our lives that determine how healthy or not we are, how long we live, and in those years of life, how many years of those life are in good health. And these determinants of health, these factors are very, very broad, and they range from social factors, your social status and standing in terms of often wealth and education and where you live, the environment you live in, both you know, the house or otherwise, where you live, and the community you live in, and the area that is in. And we've heard a lot in recent years around air pollution, and that's a really good example around an environmental factor that's important in overall health. But there are others. So we've talked around educational attainment, but also the health service has an impact on your health. Obviously, if you need healthcare in the moment, the care you receive at that time is important. But over your lifespan, the access and equity of health services is also important. But interestingly, not the biggest factor by a long way. So those are the things that affect people's health in the course of their life. And when we talk about prevention, we broadly talk about primary prevention and secondary prevention. Primary prevention are things that governments, authorities can do on all of our behalves to improve our health, and a good example of that is the smoking ban that came into force many years ago, and obviously tobacco is back on the political agenda and working its way through Parliament as we speak. But other things like the seatbelt introduction, when I was a lad, these things are important things that are done at a national level and applied to a big population make a difference to our overall health. They can include things like our approach to improving healthy weight, our approaches to improving our use of alcohol, for example. Those are the sorts of things that come into what's called primary prevention. And then secondary prevention is particularly what we do in the health service. So if we detect a condition or somebody has something, for example, if somebody had a heart attack, well, obviously they now have heart disease. So our job in secondary prevention is to prevent it getting worse. So obviously we want to pick it up in the first place, but once a condition is established, then we work to prevent it getting worse. So I go back to the heart attack example. If you have a heart attack, you'll then go through rehabilitation, you go through tests to see how the heart is working, and without question you'll be put on medications to lower your blood pressure and improve your cholesterol and so on, to prevent that worsening, or indeed prevent as best as we can having further heart attacks. So that's the sort of realm of prevention that we work in, and the health service predominantly works in the secondary space, although working with other partners across the system and wider, we certainly want to support primary prevention initiatives. Okay, Beth, if we'll have the next slide, please. And Christine, I'll follow Jim's example. I can see your hand. I'll bring you in at the sort of question time, if that's all right. Thank you. In terms of insights, the positive benefits of taking a prevention approach is picking things up early. So we do a lot of screening for health conditions through the health service. There are lots of examples of screening for disease, and we want to find them early, because we know finding serious conditions early is really beneficial to improving the outcome for those who we find them in. It is positive in terms of involving the broader community in involving themselves in prevention initiatives. So it isn't just the work that the health service does. We want to engender support out in our communities around having more awareness of conditions, and again getting to them earlier. And I think this community participation ownership is key. And I think I was reviewing in the chat box related to other comments, members were saying about self-care, finding things earlier, and something around prevention is gets us all into that. What can we do for ourselves space? What there's a lot of health understanding out there, and we call it health literacy that's out there. It's not universal, not everybody has got that level of understanding, but a lot of us do understand there are things that we can do in our own lives and to improve our outcomes over the course of them. And that's something that this holistic health is really important around. There's something about for those programs, those prevention programs, there's something broader than the health, the direct thing that we're supporting. So, exercise classes is listed there as as a prevention initiative, but it's not just about the exercise itself and what that does for your heart and general health. It's also about breaking down some of those barriers around loneliness and encouraging a broader health and well-being. And again, there's just something about supporting the term I've heard in the past, which I quite use, is just this community resilience and building leadership across communities, and what can we do from an NHS perspective to help that happen. So those are some of the positive things that we're aware of in terms of going further with prevention. Some of the concerns people have is around the access barriers. So it's not always possible to do prevention screening, for example, in people's own homes. Some of them require transport to get to venues and come in on certain times, and that always is not always easy for everybody. Awareness is a huge challenge. So I think Jim was saying, like, you've been in the health service 10 years, and sometimes we find it difficult to navigate everything, and that's the same for everybody, isn't it? It's a complex and complicated thing, is the health service, and not everybody knows about everything. And so just understanding what prevention programs are out there is one of our key challenges to help. Some of the programs aren't culturally sensitive. They're not often translatable to different cultures, and we're aware of that, and do a lot of work on supporting that, actually. But there's more to do. And one of the things I was just mentioning at the beginning is a lot of us understand this. And whenever I go to meetings, it's one of the things a lot of people say to me is sort of, Chris, we need to do more prevention, and I think I certainly support it. The challenge we've got is when you've got a health service that is incredibly pressured now, taking resource out of that to put into prevention isn't easy. It's not an easy thing to do. Where would you take it from? And that's something we're going to have to think about as we shift the balance of how we spend money, and we spend more on prevention. Just one of the concerns people have is what we stop doing to support that. And then again, there's a lot of societal concerns around prevention programs, some of the diseases that we are trying to pick up and prevent. There's still quite a bit of stigma in the general public around some of them, and that presents a barrier for people sometimes coming forward. So those are the sort of key positives and concerns. And before we go into the sort of the Slido, and before I bring Christine in, just a summary really. So what's the key challenge for us? So in that shift from the NHS being absolutely focused on treating illness to be more focused on preventing it, what could we be done to help the nation stay healthier? So that's the sort of key challenge really. And top of the list still is tobacco consumption and smoking. It's the biggest single, I think public health experts say, modifiable cause of death and disability in our society, it still is the single biggest cause. So, you know, what can we do more in that space? We're hearing much more at the moment around weight and healthy weight, and I think the stats showing there that half of our population is on a heavier weight than is healthy for them, and you know, what could we all do about that? And then this is becoming increasingly important to all of us, and I think in the chat, forgive me if I've mistaken, but I think in the chat there was some comments around children and young people's mental health. So we're acutely aware that people's mental health isn't as resilient as it's previously been, and that's particularly true, we believe, in our children and young people. So how do we also not just think about our physical health, but our mental health as well? And when I was a practicing doctor, I used to talk about, you know, physical health, mental health, and social health. And in every case I ever saw, there was always a mixture of those things. So what might the initiatives be? So more screening. So we take over screening services next year from NHS England locally. So we'll be really working hard to improve those. You know, we're supporting local authorities at the moment on the work they do around reducing tobacco consumption. And the thing about tobacco is it's not just the diseases you think of. We all think, don't we, of lung diseases, particularly cancers, particularly, but it affects lots of different conditions. It's quite extraordinary, actually, how it pervades health very generally. And obviously weight management programs, as I've mentioned. What are the sort of things we're hoping, you know, focusing more on prevention will do? Well, of course, if we prevent ill health, it will prevent disease, and there'll be less disease that needs, you know, urgent treatment and treatments at the end stage of disease. And so we'll be able to use our resources differently. I think that's the key one. And also, there's something becoming much more known in society at the moment around the contribution that staying in good health makes to society. And we've heard certainly government focused on health and work and the benefits of health to work and work to health. So those are the sorts of things that we are thinking about. And I think, Beth, this is the Slido time, and just before, while you're changing screen, let me bring Christine in, please. Thanks for waiting.
Oh, hi. The preventative, which is very important. Sometimes, well, I know for a fact that I've got a terminology that the government is shifting the goalposts, especially when it comes to cholesterol. One time at 5.6 was acceptable. Now it's gone down to 2 point something now. And mine was 5 point when I had it done about 10 months ago. And it took them 10 months to tell me I had a problem. And they said, well, we're going to put you on statins. And I said, check my record. I am not allowed to have them. I'm highly allergic. Oh, all right, then we'll put you on this tablet. You'll be fine. Had it for 3 weeks and I was crippled. And if they'd have left me, I'd have been all right. And it's took me 8 to 9 months to get the facility in my legs because I was disabled anyway and damaged before then, and it made me worse. So preventative medicine actually made me ill.
Thanks, Christine, for sharing that. And I think, not that I'm trying to prompt you in any way, shape, or form, but there's something about prevention. The thing that works for prevention initiatives is you apply them to a big population or a very, very specific population. And when you do that, for most people, for most of the time, there is benefit, but that's not universally true for everybody. It's the same when we think of vaccinations. For the vast majority of people, they work, but for some people, they are allergies or and you have to be really aware of those. So, but thanks for the comments. And if you pop something like that down and we capture it, I'd be grateful there. Let me just have a quick look just while members are feeding the Slido there, which is really good. I'll just check if there's anything on prevention in the chat that I could helpfully pick up.
Yeah, I'll just give a background of what we're asking here to everybody while you're doing that, Chris.
Thank you.
We're asking 3 questions. This is the first of 3, just to so you know what's coming on the next one. So this one obviously is around about what positive difference would it make in regards to moving more towards prevention. The next one after this is what are those concerns you might have as well. And the final one is around what you think should be prioritised in regards to prevention and why. So just to know that those are the questions coming along. So if we spend around 5 minutes on each of these, just to give some expectations as well. And just to add in, Chris, what we can do at the end of this, obviously, because yours is a very specific case that you spoke about, and obviously this is quite high overarching kind of feelings and about how we want the NHS to go towards. If you've got an individual thing that you just want to get a bit more support or advice or feedback, then we can give the details to Health Watch, which is an independent watchdog, so we can give those details afterwards as well.
That's really helpful. Just while folk are active typing, I've just a few things that are coming through on the chat that I've spotted, which is really helpful. Thank you. So there's something there around the availability and quality of food, and particularly fast food, and I know our local authorities are very aware of that with public health and how do we create more healthy environments. So that that's well noted. There's something there around the needing to focus on children, because obviously really if we can really pick things up early in childhood, we can affect hopefully positively the course of their life. The bit I've just put in there as well is that however, and I'm not just saying this as I get older myself, but however old we are, there's something we can do to change and improve our outcomes. So we talk about the life course. There are things that you do and you want to work on for children, and there are things that you want to help people work on in middle age and then in older age. So yeah, it's important. A lot of people talk to me about focusing on children, and I say yes, that's really important, and throughout the life course. Different things though for different ages, of course. We've got lots of thoughts there around that sort of looking after self, not just your health, but your sort of lives in general. And I can appreciate the thoughts that are going there. And you're absolutely right. Yeah, I think it's a really important point Christine's making in the chat there around sometimes it isn't always about saving the NHS money, is it? There's broader societal gains to this, broader personal gains to this. So I think that those would be important messages to feed in. And then yeah, the sort of colleagues that support prevention initiatives are completely different often to the colleagues that are delivering direct care. So actually the network of people just talking about prevention is huge. Anyway, sorry, I think people are still going. I can still see the typing going.
I think there's some really interesting. I think in the first section I saw quite a lot around quality of life, as Chris said at the beginning, that the people are living longer, but sometimes living longer with ill health as well. So obviously prevention could potentially reduce that as well to make sure that people are living better quality of life as well. And I've seen quite a few people speaking about teaching their nieces to cook healthy, getting fresh fruit and veg. Again, that's kind of like that foundation education that people are talking about. It's not necessarily the NHS, but that's why we spoke about those wider determinants of health. And it's a big pie that the NHS is only one section of, and it's about everybody joining those sections together. So just looking at the themes across the top as well around health, life, quality. So yeah, some really good feedback there. So I think we're ready to move to the next one, if I'm allowed.
And again, if there's anything burning that you need to as we move to the next one, you need to say, let's pop it in the chat and we'll capture it.
Still just giving me a bit of chip. Hang on, that's gone back to 2.4. Let me just figured out how to do it when it's not working now, but it just means I have to do this every time. Okay, so this one is around like what I just said around, so the concerns that you might have around this shift, so preventing sickness, not just treating it. So what negative difference or concerns that you might have around that? I think initially this is a bit of a hard one to think of, because you think, well, what could be negative about preventing? But I think it's kind of like the whole movement into a nanny state. Yeah, that's a good point. Yeah, I think we get that a lot in feedback around the communication about how things are communicated. Around, I think that just talking about that comment around, I'm being told the illness is your fault because you didn't do something to prevent it. Yeah, talk about generic rather than personalised, a blame attitude again, that's coming out. Can't change your DNA. I'll put yes at the end of that one. See a lot about how people are treated as well is coming out quite a bit as well. Yeah, around stigma as well. Just double check with Mark or Chris. There's not anything in the chat, is there? I can't see my screen properly.
I'm keeping an eye on Beth. I'm keeping an eye on yeah, I think there was something I saw earlier that I just wanted to pull out if I could. Comment around this. I recognise this personally. This isn't just an NHS challenge. This is broader, isn't it? And I think in fairness to the government, this is a very specific bit around the NHS, but there's a broader piece that the government's doing around health in general, and that concept that this isn't just the NHS's job to do. So I think more thoughts there on some of the negative biases that we just need to be careful of and sensitive to, the importance of the media and so on, and we've got a gardening advocate out there, which sure is.
I think there's some quite emotional comments here as well. It's like, I think just reading that one, you don't deserve help. It's your own fault attitude. Again, that's kind of highlighting the kind of attitude that people have flagged as well into. Yeah, we've got a couple more minutes left on this one, and then we'll move on to the next question. time. Just give everybody about 1 more minute left, everyone. But yeah, I think there's some really powerful comments in this section, I think, which I think will be really good to feed in. I'm going to try and move on to the next section. Yes, it worked. So this section is around what forms of prevention do you think the NHS should be prioritising, and the why as well. So really thinking about why should we be prioritising certain areas as well. Barbara, have you got your hand up?
Sorry, I still can't type in.
That's fine.
I was just thinking appointment times, if they were more prioritised, if this 10-year plan would get to people with mental illness, etc., prior to it getting the state where it is at the moment. So it's just a matter of getting appointments quicker.
So just to repeat that back to you then, so to prioritise appointments for people with mental health so they don't get to like crisis situations, is that right?
Well, it's not just mental health. You mentioned mental health earlier, but if people were seen sooner, say they were shortness of breath or whatever, and the whatever was wrong with them was picked up earlier, we wouldn't get to this state in the first place. Of the prevention is needed from hospitals being able to offer appointments sooner than they are at the present moment in time.
Yeah. Okay. Thank you, Barbara.
That would prevent things getting worse.
Yeah, we'll add that in as well, Barbara. Thank you. That's a lot coming through there. I think mental health is coming up there quite a lot as a theme. I did just see one comment around that it's physical and mental health need to be treated alongside each other. People mentioning waiting lists around mental health. Yeah, and people just flagging around that obviously the teaching in schools element, like kind of like that foundation level. Again, that's more around education as well, into educating people. Yeah, there's lots of comments here. I've not been able to read them all, but obviously I can see obviously there's a lot of comments at the top around there, around obviously mental health and then school as well. It's got about a couple of minutes left on this one, everybody. Was that to start moving on to the next one? Oh, the next slide. Yeah, I'll pass back over to Chris just to go on about what happened now. So it's the end of the engagement activities. I'll pass back over to Chris just to say, you know, the what next.
Yeah, look, thank you. You've got there, everybody. We've got to the end. So massive thank you to everyone for staying the course and for helping us think through this important set of questions. What it's shown me is you know, I've not seen anything from thoughts that have come forward that you know that all of us are committed to supporting the NHS get back onto a more even keel, and your thoughts around those 3 key ways for doing that are appreciated. So what will happen, so the technically will happen, is everything is captured, so that all the Slido comments, all of the chat box comments, and anything people put in verbally gets captured and fed into it. So and we'll go into the hundreds of thousands of comments from across the country that we'll receive, and NHS England and the Department of Health's role is to collate all that and bring together the consensus of what it's saying. We will have our own report that we will have from all of that, so there's you know people will be able to see that you know what's been said has been reported. That's our role here. It isn't to edit what's been said, it's to report it. That's what we've asked to do, so we'll do that. But we will take liberty as well and use some of that information to support our local planning, as I said right at the beginning, in terms of you know what are we learning as well from what you're saying. So it isn't just about helping the national NHS, it's also about helping the local NHS. Colleagues will keep everybody up to date, and I think, Beth, we're there. So all that's left for me to say is thank you. Thank you to everybody who's helped us with this. Appreciated. There's been other sessions as well, and we've had really good response from members of the public, which is fabulous to see. Huge thank you to Beth, Sean, Mark, colleagues who've helped put it together. Those technical challenges we had with just shows that these things never run smooth. There's always technicalities to get over, but thank you very much, and good night. Have a good rest of Wednesday. It is Wednesday, isn't it? It's Wednesday evening.
It's Wednesday, yeah.
Lose track. It's Wednesday evening. Enjoy the rest of your evening. Thanks ever so much. Take care, everybody. Thank you.
Big thank you to Chris and Jim as well for presenting.
Yeah.
What we'll be doing after this session as well is we'll be sending out an email, and again we'll send that link to the engagement platform. That's where you can find the slides from today. You can also find that document that we spoke about around the insight that we've looked at locally already, which is around about, I think, 36 pages that we've got so far. And when we've finished, this is the last event that we've done on our local level, which we'll be putting into that kind of like an overview report, and we'll update it on there. And hopefully we'll carry on doing this. Mark runs a monthly Derbyshire dialogue with different sessions every month. So if you're interested in that, again, just emails on our generic email address around engagement. But apart from that, I will say thanks to everybody for all of your input tonight, and I'll close the meeting from there. Thank you very much.
Thank you.
Cheers. Good evening.
Good evening.
Thank you.